Hello everyone. As a part of continuous cardiac education, our topic of discussion today is renal artery denervation and its current status, which will be presented by Dr. Pratik Rawal sir, who is Associate Professor in Cardiology at UN Mehta Hospital, having more than 7 years of experience in the field. Looking forward to your kind presence. Thank you.
Hello everyone. Myself Dr. Pratik Rawal. I am Associate Professor of Cardiology at UN Mehta Institute of Cardiology and Research Center. So today we'll be looking at renal artery denervation and the current status of RDN therapy in the treatment of hypertension. We all know that the key driver of hypertension is the central sympathetic activity, and kidney is one of the organ which plays a crucial role in the activation of the central sympathetic system. Various stimuli from the kidney like renal ischemia, renal parenchymal damage stimulates the afferent nerves from the renal artery, which in turn activates the central sympathetic system in the brain, which subsequently leads to noradrenaline release from the adrenal gland, renal vasoconstriction, renin release from the juxtamedullary cells, juxtaglomerular cells. Renin release in turn increases the activity of RAS system, and angiotensin causes peripheral vasoconstriction, and aldosterone causes retention of salt and water. So this is how kidney plays a role in increasing and sustaining blood pressure, and these mechanism is also responsible for resistance to various antihypertensive therapy. So that is why there has been a lot of interest in renal denervation, especially for patients with resistant hypertension. So what is resistant hypertension? Resistant hypertension is defined as persistently elevated blood pressure above 140 over 90 mm of mercury despite taking 3 or more antihypertensive agents, which includes a diuretic, and in a reasonable combination and at optimal doses. The prevalence of resistant hypertension among hypertensive population is around 8 to 12% in various studies, and we all know that the higher the blood pressure, there is a higher the risk of cardiovascular morbidity and mortality. So that's why it is very important to control the blood pressure. So before we diagnose resistant hypertension, it is very important to decide whether it is actually a resistant hypertension or it is pseudo resistance. So pseudo resistance is caused by various factors like poor drug compliance, faulty BP measurement techniques, improper drug combination, suboptimal doses. So all these factors needs to be excluded before diagnosis of resistant hypertension. Also, we need to screen for other secondary causes for hypertension, if any. And once the secondary causes are excluded, we need to confirm the resistant hypertension by 24-hour ambulatory blood pressure monitoring. And once it is confirmed and the drug treatment is optimized, and despite that the patient's blood pressure remains uncontrolled, then we term as resistant hypertension, and these patients can be considered for renal denervation therapy. So what is the effect of renal denervation on sympathetic activity? The key question is, does it actually reduces the sympathetic activity to the kidney? So RDN is proposed to interrupt or at least minimize the crosstalk between the kidney and the central nervous system. And one of the technique to assess this is norepinephrine spillover test. So in initial patients who were treated with RDN therapy, there was 50% reduction in the renal norepinephrine spillover. RDN also reduced plasma renin activity. Another technique is microneurography, where we can directly measure the postganglionic sympathetic nerve activity. And in 2 studies, RDN reduced the nerve firing from the sympathetic nervous system after 3 months and 6 months. So it has been clearly proven that renal denervation reduces the sympathetic activity, reduces the sympathetic discharge, efferent discharge to the kidney. And does it reduces the blood pressure? So reduction of the sympathetic activity, does it actually results in clinical reduction of the blood pressure? So various trials have been designed for this. The landmark trials, the first generation landmark studies were simplicity trials. Simplicity hypertension 1 trial was a single arm study which showed the reduction of blood pressure in patients who underwent RDN therapy. However, there was no any control group in that study, and hence Simplicity Hypertension 2 trial was designed, and it was a randomized control trial. The catheter system used here was delivered via 8 French guiding catheter, and the catheter tip was steerable via hand control, and it is connected to a console through which the radio frequency pulses were delivered, and the spacing between the pulses was around 5 millimeter of around 5 millimeter. So it was a randomized control trial. It included patients with systolic blood pressure more than 160 or more than 150 if they had concurrent diabetes mellitus, and those who were already on 3 or more antihypertensive medications. Importantly, patients with low GFR, that is eGFR less than 45, were excluded from this study. Also, the patients with significant cardiac comorbidities and severe stroke were excluded from the trial. So at the end of the 1 month, 3 month and 6 month, we can see that the blood pressure reduced significantly in the RDN group as compared to the control group. So the primary endpoint was achieved at the end of 6 months, and there was no any safety issues like eGFR as well as serum creatinine, cystatin C level were similar at the baseline and at the end of 12 months. So there was no any safety concern in this trial. Then came the Simplicity Hypertension 3 study. The Simplicity Hypertension 2 did not have any sham control. So to further refine the methodology, Simplicity Hypertension 3 randomized people and in a blinded fashion. Simplicity Hypertension 2 was unblinded study. So in Simplicity Hypertension 3, this blinding was done as well as sham control group was added to evaluate the safety and efficacy of renal denervation therapy. The primary efficacy endpoint was the mean change of office systolic blood pressure at 6 months, and the secondary endpoint was 24-hour ambulatory blood pressure, systolic blood pressure change at the end of 6 months. The safety endpoint was a composite of major adverse event which included death from any cause, end-stage renal disease, embolic events resulting in end organ damage, renal artery or other vascular complication, hypertensive crisis or significant renal artery stenosis at the end of within 6 months. So these are the results of the Simplicity Hypertension 3, and to the disappointment of the investigator, this study failed to meet the primary as well as secondary endpoint. On the left side we can see that the decline in the blood pressure was there, but it was similar in the denervation group and sham control group. And similarly, that ambulatory, on the right side we can see the ambulatory blood pressure also reduced, but the reduction was similar in denervation group as well as sham control group. So this trial failed to meet the primary as well as secondary efficacy endpoint. However, safety endpoint was met, and there was no any significant difference in the major complication between the two groups. So several reasons were postulated for the failure of these first generation studies. In that there were the methodology of conducting this study was poor, that is high rate and poorly verified drug compliance, other problems in the run-in phase and treatment phase, lack of adherence to the treatment. Also, the efficacy of RDN therapy was not measured, whether the RDN therapy is delivered optimally or suboptimally. So RDN therapy was incomplete in the first generation studies. So to overcome these limitations, the second generation studies were designed. One of the important study is spiral hypertension on medication trial. In this, a specially designed spiral catheter was used, which was compatible with 6 French guide catheter, and because of this small caliber, it was possible to treat main as well as branch renal artery and accessory renal arteries, because it has been shown that the accessory arteries and branch renal arteries also has a sympathetic nervous supply, and ablation of those denervation of those arteries also has incremental effect on BP reduction. So this is how the trial was designed. It included patients with office blood pressure more than 150 and between 150 and 180 millimeter of mercury. Patients were divided in 1-to-1 fashion between in sham control, sham as well as RDN therapy. and the primary endpoint was assessed at the end of 6 months, that was change in the blood pressure, and after 12 months unblinding was done. So this was the baseline blood pressure. Office blood pressure as well as 24-hour systolic as well as diastolic blood pressure was similar in both the group. So at the end of the 6 month, there was a significant reduction in 24-hour systolic blood pressure in the denervation group on the left hand side, and the pink one, that is sham control. And importantly, this decline in the blood pressure was maintained up to the 36th month, even after unblinding at the 12th month. And the decline in blood pressure was not only limited to the 24-hour systolic blood pressure, but also morning systolic blood pressure, daytime systolic blood pressure, nighttime SBP or office BP were all reduced to similar extent. There was no any safety concern at the 6th month, at the 36th month. So there are several limitations of this study. Importantly, that blood and urine testing for the medication compliance was done at discrete time points, and there is no adherence data over prolonged period of time. Also, the patient's exercise, diet, smoking habits were not captured adequately in this trial, and then came the COVID-19 pandemic, which disrupted everything and also resulted in poor BP control among the study participants. So to conclude, radiofrequency RDN therapy demonstrated clinically meaningful BP reduction independent of concomitant antihypertensive medication up to 36 months without any major safety concerns. To overcome the confounding effect of the medication, spiral hypertension off medication trial was designed. In this trial, patients were the antihypertensive medications were stopped for the initial 2 weeks in the patient, and after that the patients were randomized into sham as well as renal denervation therapy. The primary endpoint was assessed at the end of 3 months, and then other parameters were also assessed at the 6 month and 12 month. So efficacy and primary efficacy endpoint was 24-hour systolic blood pressure at 3 months, and secondary efficacy endpoint was office systolic blood pressure at 3 months. And the safety endpoint was major adverse event which included all cause mortality, ESRD, significant embolic events, renal artery perforation or dissection, any other vascular complication, and hospitalization for hypertensive emergency. The baseline blood pressure between two groups was similar, and there was no any safety events at the end of the first month. However, at the end of the 3 months, there was one admission for hypertensive emergency in the RDN group. There were no other safety issues. So at the end of 3 months, there was significant reduction in 24-hour systolic as well as diastolic blood pressure, and also significant reduction in office systolic blood pressure and diastolic blood pressure in the renal denervation group compared to the sham group. This is 24-hour ambulatory blood pressure monitoring. Importantly, the blood pressure lowering effect of RDN persisted throughout the day. It also reduced the morning surge in the hypertension. It also reduces the nighttime blood pressure as compared to the sham group. And we all know that the non-dippers and those patients with morning hypertensive surge, they are at a very high risk of cardiovascular events. So this was very important findings. And the same was true for the diastolic blood pressure also. The main limitation of the study was that the follow-up was limited up to 3 months. So long-term data are not available, and despite off medication protocol, 36 patients were detected to have antihypertensive drugs in their urine samples. So there is, apart from the radiofrequency renal denervation, there is also another system which is ultrasound based system, and it is called Paradise Ultrasound Renal Denervation System. There is a ring from which the ablative energy is delivered up to the depth of 1 to 6 millimeter to interrupt the nerve traffic, and the arterial wall is protected by the water circulating through the balloon. In this technique, 2 to 3 sonications lasting for 7 seconds each are delivered to each main renal artery. So the important trial with this device was Radiance Hypertension Solo. In this, the medications were stopped for 4 weeks, and then patients with mild to moderate hypertension were randomized to RDN therapy or sham group. And the primary efficacy endpoint of daytime ambulatory systolic blood pressure was measured at 2 months. And after 2 months, medications were added to achieve the blood pressure control. So this trial also showed that there was significant reduction in the blood pressure in the RDN group as compared to the sham group in the ambulatory systolic blood pressure at 2 months. And similarly, systolic as well as diastolic BP reduction effect of RDN is persisted throughout the day compared to the sham group. After the initial 2 months, medications were gradually added to achieve the BP control. And then at the 6 month, medication burden, ambulatory and home as well as office BP were measured. So we can see that in the left side graph, the top panel shows the baseline blood pressure, the bottom one, the middle dotted line shows the mean blood pressure at the end of 2 months, and the lowermost line represents the blood pressure at the end of 6 months. So we can see that at the end of the 1 month there was significant difference between renal denervation as well as sham group, but at the end of 6 months after addition of medication, the blood pressure reduced significantly in sham group also, but the blood pressure lowering effect was better in the renal denervation group. And also if we look at this data, that the blood pressure lowering effect at the end of 6 months was achieved with significantly less number of medication and lesser dose of the medication in the RDN group as compared to the sham group. So denervation therapy showed that the pill burden can be reduced with this therapy. So to conclude, the efficacy of endovascular therapy in both was maintained in both in absence as well as presence of background antihypertensive medication, and from 6 to 12 months, where after the 6 month unblinding was done. So after 6 months, the BP lowering effect of RDN was maintained with fewer medication, and there was also lower visit to visit variability in the blood pressure readings in these patients. Another trial was radiance hypertension trial. This trial included patients with severe hypertension despite having 3 or more antihypertensive medication, and after titration of medication, these patients were randomized into sham and RDN group. So 83% of the RDN and 76% of sham patients were fully adherent at the end of the 4-week observation period. And this trial also similar, just like other trials, showed that the blood pressure reduction is significantly better in the RDN group as compared to the sham control. The office BP as well as home blood pressure also reduced to similar extent, just like ambulatory 24-hour blood pressure. And this is the urine measurement of the antihypertensive medication, and 75% of the subjects were fully adherent at the baseline and at 2 months of trial. There was no any major side effects of this therapy. So to conclude, the patients with resistant hypertension who are already on triple combination therapy, the ultrasound based RDN was associated with reduction of blood pressure of 8 millimeter of mercury in the daytime systolic blood pressure, and the BP lowering effect of RDN versus sham was consistent for 24-hour, night time as well as office systolic blood pressure. So to summarize, the second generation trials showed that the RDN reduces the blood pressure consistently across a variety of hypertensive patients, including mild to moderate as well as severe hypertensive patient, and that too in the presence as well as absence of concomitant antihypertensive pharmacotherapy, thereby addressing the confounding effect of the medication on the effectiveness of RDN therapy. So to summarize, these are the second generation trials which clearly shows the systolic ambulatory as well as diastolic ambulatory blood pressure and office blood pressure reduced significantly in all the major second generation trial as compared to the sham control. So what is the durability of this blood pressure lowering effect of renal denervation therapy? So this is one of the limitation of RDN therapy, in that the durability has not yet been sufficiently investigated, because all these RCTs reported result at either around 2 months, 3 months, 6 months. Long term follow up is not available. However, there is one registry, that is Global Simplicity Registry, which has got data up to 3 years. And as we can see that on the right side of these on both the graph, we can see that the blood pressure lowering effect of RDN is maintained as the year progresses, and even the BP control is better as the time passes. So one of the mechanism that has been postulated in the reduced efficacy of this RDN therapy over long term is that re-innervation of the treated kidney. In experimental animal studies, it has been shown that there is regrowth of the renal nerves and partial recovery of the sympathetic system. However, this has not been demonstrated in the humans. So does renal denervation therapy improve cardiovascular outcome apart from reducing blood pressure? We do not have any direct randomized study which has assessed the cardiovascular outcome of RDN therapy. However, we do know that as the blood pressure rises, the incidence of cardiovascular events increases, and multiple trials of blood pressure reduction therapies have shown that reduction in blood pressure results in reduction in cardiovascular events. The reduction of office blood pressure by 10 millimeter of mercury leads to a large relative risk reduction in cardiovascular events as well as mortality. So blood pressure reduction, whether achieved by drug or RDN therapy, reduces the cardiovascular complication, that has been clearly established. So what is the safety of these therapy? In all of the randomized sham control trials, the rate of major adverse events were similar in both the RDN as well as sham control group. There was a low incidence of acute micro injuries in the RDN group that was observed by OCT technique. However, there was no any long-term clinical sequelae of these micro injuries. Also, the annual incidence of renal artery stenting following RDN therapy was around 0.2%, which is comparable to the natural incidence of renal artery stenosis and renal stenting. Patients with eGFR less than 40 to 45 were excluded from almost all of the trials. So the safety of the RDN therapy in these patients who have deranged renal function is not clearly established. However, there is small pilot study which recruited the patients with low GFR, and it reported no safety concern with the RDN therapy. So what is the gap in the knowledge as far as the RDN therapy for hypertension is concerned? There are many things that we still do not know. One important thing is predictors of blood pressure response to the RDN therapy. Many factors has been postulated, like baseline heart rate, baseline blood pressure, obesity, obstructive sleep apnea, other comorbidities, but none of the factors has been studied to predict the response to RDN therapy. Another important point is that the procedural efficacy of RDN is difficult to measure, and there is no direct comparison of different ablation technologies, like whether radio frequency is better or ultrasound is better. There is also another technology, that is alcohol ablation technique. Another important issue is that long-term durability of blood pressure lowering efficacy of this treatment is not yet known, because all the trials are in initial phase and has reported only short-term data. Patients with low GFR, whether they respond to this therapy and whether this therapy is safe in those patients is not yet known. And similarly, the patients with hypertensive comorbidities like CKD, AF, heart failure, all these patients were excluded from this trial, and the effect of RBN remains to be established in this group of patients. Also, the cost effectiveness analysis is also lacking, and the patient population of isolated systolic hypertension, how this therapy performs in this group of patients is also not known. So these are the three main techniques: radio frequency, ultrasound ablation, and alcohol method. So what is the current recommendation? Recently the European Society of Hypertension published a position paper, and this paper has concluded that the RDN therapy is a safe endovascular procedure. There was no any major safety concern up to the 3 months, and this therapy was deemed alternative or additive. It is not considered as a competitive therapy. It should not replace the traditional medication which has been shown to improve renal as well as hypertension outcome in patients. So this therapy can be considered in patients who require multiple drugs and those who developed frequent side effects of this therapy. In those, this therapy can be considered. And the committee also recommend that each institution should have its structured pathway for optimal use of RDN therapy, and of course patient preference and patient perspective also needs to be taken into consideration. Some patients may be reluctant to undergo procedure, they are happy with multiple medication, while some patients don't want to take so many pills and they want to get rid in one go. So in our scenario, if we see a lot of patients who are not only on 3 medication, they are on 4 or 5 antihypertensive medication, and despite taking these therapy, their blood pressure is not adequately controlled. And there is also we don't often find secondary causes of hypertension in such patients. So these patients can be considered for renal denervation therapy, and we can conduct studies on such patients who are on multiple antihypertensive therapy, including central sympatholytic agents like clonidine. And so these patients can be included in the studies of the RDN therapy in our setup. So this was all. Thank you very much for your patience hearing.